speaker, Dr. Ramanan. Dr. He is a leading global expert and one of the most active proponent of work which he does. He is a founder and a president of One Health Trust, and he earlier had an association with CDEP, which has done some phenomenal work. He's one of the most accomplished AMR champion globally, and he's a senior researcher scholar at Princeton University. He's an affiliate professor at university, so he's been associated with all Ivy Leagues globally, and that's a true accomplishment. University of Washington, he's a senior associate at Johns Hopkins, Bloomberg's School of Public Health, visiting professor at Strathclyde in Scotland. He a board chair at Health Cubed, founder member of US President's Council of Advisors for Science and Technology with Obama's administration. That's something which is really path-breaking. Fellow of American Academy of Advancements in Science and Infectious Disease Society of India, of America, member of the Council on Foreign Relations. He's leading the largest COVID-19 epidemiology project globally. He is named as, and if the alma mater recognizes you as one of the distinguished alumni, I think greater than that, and that did occur with Ramanan, with Birla Institute and University of Washington. Was awarded Ella Pringle Medal by Royal Politicians and people. He has worked extensively. He's worked in India. He's worked in Kenya, Mozambique, Nepal, South Africa, Vietnam, and his areas of expertise definitely is an economist, but One Health and vaccines, WASH. So it is extremely great to have Dr. Ramanan, and I will to really waiting, excited to you. So he will be working on state of world antibiotics and 20. You, Dr. Ramanan.
Thank you, Dr. Sanjeev. Good to see you after such a long time. Congratulations to Dr. Meher and the organizers. This is indeed a really impressive forum, and I look forward to seeing some of the other presentations as well. And it sounds like the idea of MR is really taking off in the Gulf states in terms of research advocacy, and this is what we really need. As many of you know, we're going into a UN General Assembly high-level meeting on AMR next year, and one of the things that we really need to collectively agree on are targets or improvements that the entire world will make, and that will then trickle down into what regions and states will make. And in fact, we're working on a Lancet series, which is around what these targets will really look like and how you can ensure that progress is made in every part of the world. And AMR is indeed a very, very difficult challenge at one level, but at the same time, there are some simple things that we do have good evidence for, which is what I'd like to focus on. So I just wanted to give an overview on the state of the world's antibiotics as we see it in 2023. This is also the subject of a report that will come out later this year, or actually probably next year. And we bring it out every 2 years on sort of summarizing where things stand. We put out a drug resistance index, which is basically like a stock market index. So you think of a stock market as in one number, it's telling you how well the market is performing. This is an index that tells you how well with our antibiotics are performing. And as you can see in most countries, 2020 relative to 2015, resistance has gone up. These typically get published in the Financial Times because this is this easy summary number. Countries like India, Turkey, Argentina, numbers are already quite high, so not a huge amount of increase. We've seen work from the University of Washington, which shows 1.27 million deaths attributed to antibiotic resistance and close to 5 million deaths associated with antimicrobial resistance, which means that if you combine HIV, AIDS, and malaria, that is only slightly above the ones that are directly attributed to antimicrobial resistance, and certainly much less than the number of deaths associated with antimicrobial resistance. And if you look at it by pathogen, obviously E. coli is right up there along with staph. Klebsiella is now the leading cause of sepsis in newborns, And sepsis itself accounts for about 25 to 30% of all newborn deaths. So it will be very hard for us to make progress on child survival around the world unless we tackle AMR. 1/4 of the deaths that are linked to drug-resistant diseases, all the diseases where you could have drug resistance, are because of AMR. So, many of you've worked in this area for a while, and you can see the steady progression of how much things are getting worse every year, simply because the drugs are failing. And this is again the global burden, highly focused in South Asia and sub-Saharan Africa. And it's a combination of three things: how much underlying disease you have. Second is, of course, how much of the bugs are drug resistant. But the third part is also access, which is how much access do people have to effective antibiotics. Chances are that if all these people in West Africa had the same level of access to antibiotics that people in Europe did, their mortality would be much less. So we've got to keep that in mind. And the consumption is very different in different parts of the world. You have some pockets like Vietnam or Serbia or Turkey or Spain, which consume more on a per capita basis. But by and large, the average I would use is that across high income countries, defined daily doses is about 30. Across low and middle income countries, it's about 17. So half of that. So there's a big difference between how much rich countries consume and poor countries consume, roughly a factor of 2. And it is not warranted by any sort of health need. And these are data from India showing that the causes of multi-drug resistant infections are varied. They are gram positives, they are gram negatives, different antibiotics at work. And so it isn't simple like with malaria or HIV to really tackle it with one tool. We have to rely on many different approaches and many different tools to be able to tackle AMR. The mortality odds are really what cause concern. This is, essentially multi-drug resistance and extensively drug resistance in terms of mortality odds with patients with these infections. And, the odds go up to almost 3 times when you have extensively drug-resistant infections. And this is the reason why all these get translated into big mortality numbers. Now, underlying this is the fact that ESBL carriage rates have been going up. These are individual studies and study sizes. And regardless of region, between 2001 and about a decade later, ESBL carriage rates had gone up quite a bit, but most of all in South Asia. And that then translates into resistance, but not always the case. In India, for instance, Streptococcus pneumoniae, pneumococcal pneumonia is still highly susceptible to penicillin or amoxicillin. The problem, however, is that availability of penicillin remains quite poor because no pharmacist is able to make money from selling these drugs because they're all busy, trying to sell far more expensive and unaffordable antibiotics. The mortality outcomes, particularly in newborns, is much worse. So if you have a positive culture, almost a 30% mortality rate, and if it's gram positive versus gram negatives have a higher death rate. And then, of course, ESBL or MRSA, then you exceed a 50% case fatality rate here. And like I said, Klebsiella pneumonia is now the leading cause of sepsis deaths globally. This is based on data that we just published last year, combining 3 studies, NEO-OBS, done by GARD-P. The second was CHAMPS, which is funded by the Gates Foundation. And then the third is the Barnard study, which is done by Tim Walsh out of Oxford. And everywhere we see the same consistent story there. This is the Dennis study that was done a few years ago by Dr. Vinod Paul and the team out of AIIMS, but covering a few hospitals in Delhi. And you can see that the case fatality rates in culture-positive sepsis was extraordinarily high. It was high even when you had a sensitive pathogen, but it goes up another 15 to 20% when you have a resistant pathogen. And this is what we really face, which is that it is very difficult to make progress on newborn survival unless we really tackle AMR. And we estimated a few years ago the global neonatal sepsis deaths caused by bacteria resistant to first-line antibiotics. This was in a Lancet series. We estimated about 214,000 deaths a year, and that number has again gone up now. These are just in the 5 countries with the most numbers of newborn sepsis infections. And this study actually made the cover of the New York Times, but it summarized very clearly what the challenge was, which is there's a threat to India's babies, but they also pose an overseas threat in terms of resistance. Then, spreading around the world. They emerge in many countries, but certainly the places where infection control is weakest. Now, the other population at risk is really the elderly population. This was a study that we published on absolute risk reduction of infection with antibiotic prophylaxis for common surgical procedures, showing that for things like colorectal surgery, your risk of infection is about 25% if when antibiotic susceptibility is not that great. And if you look at any of these procedures, these basically constitute what we consider modern medicine. And we do run a real risk that surgical outcomes are across the board becoming less reliable because of drug-resistant infections and may even deter patients from going for these procedures. And these were data from the US going from 1980 to about 2005, or 25-year period. And you can see that the infection probability has actually gone up significantly, especially for colorectal surgeries. But some for some of the others, but really most markedly here, where the risk of contamination and loss of sterility is an issue, and having a drug-resistant pathogen really does make outcomes much worse. And we estimated about 6,000 additional deaths and about 120,000 additional infections because of the reduced effectiveness of antibiotic prophylaxis. And this is the kind of work that we need to do in other parts of the world, because we need to reach a broader set of stakeholders beyond the infectious disease community to show them that their own treatment outcomes are at risk because of AMR. Now, some communities, like with cancer, certainly with C-sections, have started to understand this, but still, not quite there as far as where we need to be. Urinary tract infections, this was never really an issue, I would say 15, 20 years ago, but today, these are commonly reported about UTIs turning deadly, and we really lack antibiotics to deal with this. Again, these are examples from India, but this particular long-form article was from the New York Times, covering many women in the United States who have had UTIs and have either died or have infections that have not been treated after a very, very long time. Sorry, I'm going to skip this and just go to gonococcal infections. Now, we've had many drugs for gonorrhea over a period of time. We started losing them with the loss of penicillin in the 70s after during the Vietnam War, when they were extensively used in Vietnam in brothels. And since then, we're down back to where we were back in the 1920s, which is we now have no reliable drugs. We had no reliable drugs in the 1920s. There is hope that a drug called zoliflodacin, which has been developed by GARD-P, an entity whose board I'm honored to chair, that drug may actually, if it were to be successful in phase 3 trials, could be a solution here. But again, we have to remember that every drug is only a fix for a temporary period of time. And unless we make some permanent corrections, either in terms of how we use the antibiotics or whether we have vaccines for them, we're going to be stuck in this kind of a cycle for a long time. All these bugs move very fast around the world, as you're all aware. NDM1 first detected in Indian patient in Sweden, but now nearly every country around the world. Similarly for MCR1, which is detected in pigs, but is now literally in every country around the world. And it truly is a One Health problem. I think discussions like these, as Dr. Rizvi started out by saying, we cannot constrain ourselves to just a human domain or even a human and an animal domain, unless we are able to consider a fully One Health approach, which is really the idea that we live in a connected world. But the outcomes are all felt with respect to human and animal health. We're not going to be able to solve the problem. Now, meanwhile, antibiotics continue to be overused and misused widely. This was the highlight of our 2021 report. And we can see that, from the MALED study, use of antibiotics in kids under the age of 2 in 8 countries, a lot of antibiotic consumption in children in South Asia, and a lot of antibiotics are given for bloody diarrhea, for diarrhea without bloody stools. And worse than this is, I didn't have time to summarize the NeoOp study and data that has come out since then. We see a lot of newborns now, up to 80% of the most recent data that we have, all being put on meropenem within a week of being born, 80%. And these are in situations where they're almost being given prophylactically. And we've truly arrived in a place which is quite depressing, to be honest. We do see an increase in consumption globally. We have a simultaneous access and excess problem, but we do see convergence. By convergence, what I mean is that in the rich countries, the defined daily doses per thousand inhabitants has been going down. It's been going up in many of the poor countries. And there is still a huge divergence in consumption between rich and poor countries. In fact, you can see that upper middle income countries are starting to converge with higher income countries that are flattened out. And with the low and lower middle income countries, it's starting to go up, but not quite caught up, right there yet. And by the current forecast that we made in 2016, if we continue this kind of growth, we will have a 3 times consumption of antibiotics by 2030. If we have the global convergence and stay there, we will get to just about 20% more or 10% more. However, what we really want to aim for is no future growth, but a rebalancing. We need to see places which are consuming too much, which is even within a specific country. So even take a country like India, there is excess consumption in the cities and there is lack of access in the countryside. And that needs to be corrected somehow. And of course, India ranks #1 for consumption of antibiotics globally because it is a largest country by population size. But this is only when it comes to humans. When it comes to animals, you'll see in a bit that China consumes far more. Now, the idea of access, watch, and reserve antibiotics is a very important one. We see that particularly the top chart is about access antibiotics, and that use is actually going down in countries like India, Pakistan, China, even Russia, and parts of Eastern Europe. Now, part of this could be just because the access antibiotics don't work any longer, but another important reason is because we are really losing the plot on stewardship. We're losing the plot, and I don't mean hospital stewardship. I mean, with respect to all antibiotic consumption, we have very strong commercial pressure to sell newer antibiotics, and that's what's playing out right now. And if you look at the proportional consumption of oral antibiotic formulations for young children, the access is this dark blue part, and then the watch and reserve. And you can see in countries, China, Bangladesh, Japan, the access is a much smaller proportion and compared to the watch and reserve. And this really is a troubling situation. The link between antibiotic consumption and resistance is not consistent globally. These were the data that we used to rely on from Herman Goossens' data from Europe, showing that there was a very nice 45-degree line if you plotted each country use of penicillins and penicillin non-susceptibility in Streptococcus pneumoniae. And at one end was France, and the other end was Netherlands, and this was a nice story to be able to tell. And this was also a story that we found in the studies in the US as well. This was actually done by a student of mine right here in Princeton University, showing a very nice 2-month lag between prescriptions and resistance. But in more recent data, which covers the world, not just high-income countries, there the situation is much more confusing in that consumption does not seem to be single-handedly driving resistance. There are many other factors, including governance, including health expenditures, education, GDP, that all are associated with changes in resistance. And so we need to really spend a lot more time thinking about what's driving resistance. It's without doubt that in combination with these, consumption will play a role, but not all by itself. Now, lack of access to antibiotics is a major problem. I want to highlight that because we often lose that in the shuffle. We just tend to think about resistance. And the way to think about it is simply that providing access for millions of people without antimicrobials is important. We also need to balance that with conserving the effectiveness of the drugs that we have. And we also need to create new antibiotics. I think all three are going to be very, very important. But access without conservation and innovation is going to be a waste of money because we will just speed up resistance. Conservation is going to constrain access, and it does undermine innovation because if you're using less of the drug, nobody wants to make that drug. And innovation without providing access is unfair, it's unjust, and without conservation, it's wasteful. So this is really the three-legged problem we're trying to solve here. And the answers are not always easy, but I think we've made a lot of progress in the last decade. As I mentioned, pneumococcal pneumonia, a lot of these are treatable with penicillin, which is simply not easily available in many parts of the world. And we estimated avertable pneumonia deaths, avertable with improved antibiotic access, to be quite significant in many parts of the world. Now, why are antibiotics overused? This is crude infectious disease mortality in the United States. It's been going down for a very long period of time. Now, in South Asia, today, the crude infectious disease mortality is what it was in the United States in 1922. What it is in Sub-Saharan Africa is what it was in the United States in 1910, which means that we are using antibiotics not as a complement to public health, chlorination, water, sanitation, hygiene, but rather as a substitute for these. And that is not a way in which we can sustainably use antibiotics. We simply have to invest in vaccines and water and sanitation and IPC before we're really talking about resistance. Now, the incentives for antibiotic prescribing are all in the wrong place. We have hospitals in China deriving significant revenues from the sale of antibiotics. In India, public health facilities may have good supply of watch and reserve, but not access antibiotics. And many people who are prescribing these antibiotics don't actually have a medical degree. They really are, we literally allow anyone, and this is, I just give an example from India, but this is true in many countries in the world and also in South Asia and Sub-Saharan Africa. And, shockingly, even in parts of Europe, where, there's a lot of use of antibiotics without prescribing in Italy and Spain and so forth. And the incentive for physicians are really to satisfy patient expectations. We see that around the world. If patients expect antibiotics, the antibiotic gets prescribed. And then we also have decision fatigue increasing inappropriate prescribing. We see that, as the physicians are going on later on in the day, they end up prescribing more antibiotics. We see that even in the best hospitals in the country, in the United States, there's a lot of use of antibiotics without using of culture. And even if patients are afebrile, have normal white blood counts, and even if appropriate cultures are collected, they still stay on antibiotics. There's very little de-escalation, and this is an area for us to really focus on. So I'm just going to move very quickly to my last few thoughts here in the interest of time, and just to say that we do have an issue with stewardship and how much we invest in stewardship, and the answer is we invest way too little. We're investing far more in new antibiotics than we are in stewardship. But every act of stewardship is delaying the need for new antibiotics. I know, in the medical fraternity, in the public health fraternity, everyone is grasping for a solution. But, simply, paying for new antibiotics, which is important, by the way, it's very, very important. But it's like saying my car broke down because the road is bad and the solution is to buy a new car, whereas the real solution is really that we need to fix the road. And we really need to fix the way in which we're using antibiotics. Vaccines are a very important way in which we can help reduce antibiotic resistance and consumption. A lot of work that has happened in this particular area in the last 3 or 4 years, a lot of quantitative data. And if I had to bet on how we will make progress on AMR over the next few years, I would bet that it's going to be a combination of vaccines, infection prevention and control, and water and sanitation. And the combination of these three, along with efforts to improve antibiotic access, can actually reduce antibiotic consumption and also reduce the burden of resistance quite significantly. I've spoken mostly about humans, but there's a whole animal side to the story, which will take quite a bit of time to get into. But in the interest of time, I will stop here. And thank you all for listening. It's been a pleasure.